Hi, everyone. It's a real pleasure to be able to introduce Dr. Julius Gilayeneh, who I had the privilege of meeting in 2016 when he was here at the Madison and a Distinguished Mandela Washington Fellowship as part of the Young African Leaders Initiative program that UW-Madison was hosting. And he came to Madison as a young MD who was trained at the A.M. Dolioti College of Medicine at the University of Liberia, and really learned the skills of medicine practice in a situation that was kind of trial by fire. He was serving as doctor in the largest no-fee-for-service public hospital located in the capital city of Monrovia at a time when the Ebola outbreak, the 2014 to 16 Ebola outbreak, hit Liberia, Guinea, and Sierra Leone. And he was deployed to provide support during the EBD epidemic to the county health team in one of the hardest hit counties, Margibi County, at the time when a record number of health workers were reported dead from the county's primary public hospital due to EBD infection. And EBD was spreading rapidly in the country. After he did his Mandela Washington Fellowship here at the UW-Madison, he went on to the University of Oxford, where he obtained a Master of Science in International Health and Tropical Medicine, and then returned to Liberia, where he has served in various capacities within the health sector, including being the head for Epidemic Preparedness and Response at the National Public Health Institute of Liberia, and Deputy Program Manager for the National Malaria Control Program of the Ministry of Health of Liberia. He currently serves as the Deputy Director General for Technical Services and Chief Scientist at the National Public Health Institute of Liberia, where he is responsible to provide technical oversight and supervision over Liberia's disease surveillance and emergency preparedness and response systems, laboratory diagnosis and quality standards at the National Public Health Reference Lab, public health workforce capacity building, as well as environmental and occupational health activities. So you see he has a very broad reach overseeing much of the health sector in Liberia. And I can say, as someone that has been traveling to Liberia for over a decade, one of the things that has been really astounding is the transformation of public health infrastructure in Liberia in the post-Ebola period. Dr. Gilayeneh is one of the people that has played an important role in that transformation. It's also an honor to have him as a scientific advisor on a European Research Council grant that I am currently the PI on, based at the Rachel Carson Center for Environment and Society in Munich, in which we've brought together an interdisciplinary team to look at the economic, environmental, political, and social forces at play that have turned the upper Ghanaian forests of Liberia and Guinea into hotspots of emerging infectious disease, biodiversity conservation, and natural resource extraction. So without further ado, please join me in welcoming Dr. Julius Gilayeneh.
Thank you, Professor Mittman. Good afternoon. Let me firstly start by saying how greatly delighted I am to stand before you as a guest speaker at this Africa Unknown program, where you bring together academicians, researchers, students, policymakers from different backgrounds to discuss topics of interest and ways to advance development across the African continent. Very much honored to join our previous speakers at this forum. I do vividly recall 7 years ago my first visit to Madison when, as mentioned by Greg, I was a part of a group of young African professionals accepted for the Mandela Washington Fellowship Program. And we came to participate in that fellowship program at the University of Wisconsin, Madison. It was an amazing experience, interacting with other talented professionals from across the African continent. And it is something that I can never forget. I can never forget the warm Wisconsin welcome that we received, the many great insights from the lectures and discussions that followed those lectures. I also do clearly remember community service at the food pantry and other community service activities, the amazing view at Lake Mendota. I think that's it, right? And of course, the 4th of July fireworks at Lake Mendota. But most importantly, I remember how engaged, how committed, and how passionate the staff at the African Studies program, lecturers and other individuals who met here at Madison were towards human capital investment in Africa. Before I start my presentation, let me point out that Professor Greg Whitman is one of those persons, and I have had the privilege and honor to interact with him over the past time. He's been very committed to human resource development in Africa, specifically in Liberia, for almost 40 years, and research as well. And currently we are collaborating on a project called Fragment of the Forest, where he's training 2 PhDs in Liberia and 1 in Guinea. And they are looking at the ecological landscape and why the Upper Guinean forest has turned into a hotspot for biodiversity. So thank you, Greg, for your contributions, and thank you for organizing this meeting. So let me ask that you kindly give me a few minutes of your time to speak to you briefly on the topic, the afterlives of Ebola, advancing public health and scientific research in Liberia through mutual and beneficial and sustainable partnerships. So this is basically the structure of this presentation. It's divided into 4 parts. And the first 2 parts will basically give us the context and background of Liberia as a country and what happened during the EVD epidemic. And much of the focus will be placed on part 3 and 4 that look at post-EVD investments and how they've transformed the public health landscape in the West African country of Liberia, and what are some of the current research capacities, the gaps and opportunities for partnerships in Liberia. So in terms of the country's context, Liberia is a small middle-income country in West Africa, about 43,000 square miles in size. And to put that into context, it's about the size of the state of Tennessee in the United States. And compared to Wisconsin, Wisconsin is about 1.3 times bigger than Liberia. It was founded in 1847 by formerly enslaved persons from the US and the Caribbean who were repatriated to the west coast of Africa by the American Colonization Society, which demonstrates the strong political and economic ties between Liberia and the United States of America. We, as a country, our first constitution was modeled after that of the United States. In fact, was written by a professor from Harvard University, John Simon Greenleaf. Our flag is one of few flags on the African continent that doesn't have red, yellow, and green. And Because Liberia was not colonized, and thanks to the American influence at the time, Liberia is considered the oldest independent country in West Africa. There's so much to study about this small West African country in terms of the history, the culture, the people, and its link and ties to the United States. According to the 2022 population census, there's an estimated 5.2 million people in Liberia. It's a very youthful and productive population where about 50% is between the ages of 15 to 49 years. The percentage will increase to almost 90% if you were to consider between the ages of 0 to 49 years. So it tells you that it's a very young population. As a post-conflict country, Liberia is still struggling from the devastating effect of the 14-year civil crisis that took the lives of almost 250,000 persons and have adversely impacted various fabrics of the Liberian society, including the economy, the workforce, where the already scarce human resources, most of them had to migrate to other developing countries to seek greener pastures. We've also had impacts on the educational system, the infrastructure, the roads, the health system in particular, where most of our health indicators are particularly poor. There's high maternal mortality rate, there's high infant mortality rate, child mortality rate is high, there's high out-of-pocket expenditure for healthcare services, and about 29% of the population live within 5 kilometers within more than 5 kilometers to nearest health facility, which makes healthcare delivery even more challenging and difficult. Peace was restored after the war in 2005, following interventions from the UN and ECOWAS. The process of rebuilding and recovery is ongoing. It may be slow by some accounts, but we are making progress as a country. Notwithstanding, the country is still fragile on several counts. In terms of the economy, there's a high level of poverty. More than 50% of the population live on less than $1 per day. We've already indicated an enormous challenge within the health system. The security sector remains fragile, and there are challenges with infrastructure and basic social services as it relates to availability of electricity, running water for the populations. And there's also poor road network, as I indicated earlier. In 2017, Liberia had a successful transition from one democratic elected government to the other. And that was the first in 73 years since 1944, which is a sign of progress with our democracy. And 6 years later, in 2023, we are expecting another democratic elections in October of this year. The 2014 Ebola virus disease epidemic in Liberia was firstly reported in March of 2014. There are accounts that Ebola may have been circulating in Liberia way beyond this period, but because of the inadequacy of the health system to promptly detect disease outbreaks at the time and set up an appropriate response mechanism to respond to these kind of outbreaks, we realized that by the time those cases were reported, they were spread beyond there were geographical spread beyond where the cases had initially started to other parts of the country, which made it very difficult to contain at the moment. Some of the health system vulnerabilities I listed up on the slide. We have poor preparedness for epidemics, weak surveillance system, poor diagnostic capacity, and inadequate response structures. There were challenges with the health workforce that was ill-prepared at the time for an outbreak like Ebola, and health workers were poorly motivated because of salaries and other issues as it relates to incentives. The health infrastructure at the time was unfit, to handle an outbreak of that scale and intensity. So there was already an existing infrastructure that provided poor quality care. There were poor infection prevention control practices and weak supply chain. Because I'm looking at public health and research in Liberia post-EVD, I thought to highlight also that the research infrastructure and data management systems within the country was very poor. The implications for these will be highlighted later in this presentation. The EVD epidemic had an adverse impact on the health system in Liberia. The table here shows the number of cases, over 10,000 cases, and about 4,800 total deaths within Liberia. And across the sub-region, over 28,000 cases and 11,300 deaths. Routine health services during the EVD epidemic were significantly disrupted. And this was as a result of health facilities closing down. The picture you see here is in Joseph Catholic Hospital, one of the oldest hospitals within the country. And this facility is touted to be one of the only hospitals that remained open throughout the 14-year civil war, where Ebola shut it down. In fact, this was where I was born a couple of years ago. And because of the breakdown in the health service infrastructure, there were low uptake of routine health services. Immunization services dropped. Services for maternal and child health were not available to the population. And there was lack of trust within the population with the health system. And because of that, it may have also led to the increased transmission, because people within communities were seeking healing from traditional leaders, from nurses and midwives at their homes, and the condition continued to spread from one person to another because of those issues. And because of the lack of confidence in the health system, like I mentioned earlier, routine services also dropped. During the introduction, Greg did indicate that I worked at Redemption Hospital. That hospital is the largest free for service hospital within Liberia. It is located in one of the biggest slum communities, Nukru Town, and serving other adjacent large slum communities. In March of 2014, Redemption was hit with the first case of EVD. I still clearly recall that as a young physician at the time, I had a pediatric case, a newborn that I did suspect bowel obstruction at the time in that newborn, and I sent for a surgical consult with one of the surgical consultants at the time. We examined that patient together. 2 days later, we were told that he started manifesting symptoms of Ebola. For those of you who know the clinical picture of Ebola and how symptoms develop, he may have already been infected at the time when we had interacted. So there was fear across the hospital, and I can say for sure that when I heard the news, I never went back to the hospital again until the hospital was reopened after a month later. And this was the case with many of my other colleagues and other health workers, because within a period of a week, we realized that if you look at this case study, you see that within a period of a week, we realized that over 20 health workers at the hospital had already gotten infected. By the time we reached to a month after the first case was reported at Redemption Hospital, the health facility shut down, both inpatient and outpatient. You can imagine the chaos and the challenges at the time, considering where that facility was located and the disadvantaged populations that it served at the time. Between June of 2024 to around, between June of 2024 to around August, almost 2 months, the inpatient services were restarted, and it took about 6 months later to reopen both inpatient and outpatient services. But guess what? Within a week of reopening the inpatient services, another case was reported. And 2 weeks later, a second case was reported, and the hospital shut down. So it just shows how vulnerable the health system was at the time in terms of infection prevention and control, and how healthcare workers were vulnerable to spread of infections, which may have also led to fear among healthcare workers to abandon some of the health facilities at the time. Ebola also did not just have an impact on the health system, but there were also economic consequences. The World Bank projected that GDP growth for Liberia would have dropped from around 7.5% to around 5% in 2014. But as a result of the EVD epidemic, we had 0% GDP growth, and it was reported that about 2.2 billion in growth in GDP was lost in Guinea, Liberia, and Sierra Leone in 2015. Limited research studies occurred during the EVD. When I say limited research studies, I mean limited endogenous research studies. Most of the research that happened at the time were led by international researchers, big research groups, big pharmaceutical companies, prestigious universities that were interested more in trying out some of those novel therapies. And that is often the case in most developing countries, compared to the supportive care interventions that the local physicians thought were helping to improve survival of the patients. So as a result, despite an outbreak the size and scale of Ebola within West Africa, most of those supportive care interventions could not be tested because the agenda was mainly foreign-driven, and those providing the funding had other interests. Convalescent plasma, for example, which has been shown over a period of time from previous EVD outbreaks since the 1970s in Uganda to improve patient survival, could not be tested in countries like Liberia because by the time those decisions were made, we were almost towards the tail end of the epidemic. And this missed opportunity was basically because of the limited in-country capacity. There was lack of resources, and there was also lack of human resources and financial resources. The human resources to design essential research questions to help us make prompt decisions as healthcare providers, and financial resources to support the conduct of these research activities. Unfortunately, most of the data collected within the system at the time during the EVD epidemic was of poor quality, and as a result, up to this date, there are still challenges with or difficulties with making sense of what is available from the EVD epidemic. And that was as a result of the poor data infrastructure. And it's also important to note that regulatory mechanisms for research were practically non-existent in Liberia. So there are accounts of instances where some research may have been conducted, data may have been moved from one place to the other, samples may have moved or changed hands from one place to the other, and this is also not uncommon in most developing countries. Thankfully, we've evolved over the period of time to have strong research regulatory systems and mechanisms in place to ensure that data that is generated within Liberia is protected, it's shared through agreements that are signed by both parties, and ownership remains for the collecting country. Following the EVD epidemic, like I indicated earlier, a lot of investment have been made in the health system, and we've seen a lot of progress. This is the strategic framework for the post-EVD investment in Liberia, which look basically at building a resilient health system. And these areas highlighted in blue are the 3 pillars, looking at the workforce, re-engineering the health infrastructure, and epidemic preparedness and response. And there are cross-cutting areas which include research. In the interest of time, I will just skip this slide and move on to the next. I thought from the previous figure you see listed here to highlight these 4 areas because they specifically relate to the work that we do at the National Public Health Institute: research, partnership, workforce or capacity development, epidemic preparedness and response, and re-engineering the health infrastructure, which led to the establishment of the National Public Health Institute in 2016, 17 thereabout. With respect to research partnerships, currently we have in country the Partnership for Research on Ebola Vaccine in Liberia. And this was a joint US government, Liberian government partnership that looked at Ebola vaccines and therapeutics at the time. But that partnership has evolved and expanded over time to include other infectious diseases like HIV, malaria, Lassa fever, COVID-19, etc. And PREVAIL has also helped to provide training opportunities for Liberians. The infrastructure and setup through the PREVAIL mechanism has been utilized on some occasions and from time to time to help support the diagnostic testing capacity within the country. And that platform has been one of the primary platforms in Liberia for scientific evidence generation to inform policies. I thought to borrow this slide from one of the PREVAIL presentations to highlight a key point. In August of 2014, the Minister of Health of Liberia did write his counterpart, the head of Health and Human Services, the Secretary of Health and Human Services of the US government, requesting support for collaboration between the 2 countries for joint clinical research on Ebola. It took 2 months to get a response, to send a scientific team to have direct discussions, to look at the possibility of starting this research project. If we invest in research infrastructure in developing countries, it helps to build the capacities and support these countries that are usually prone to outbreaks of infectious disease to develop their own proposals, answer some of those essential research questions that will help us to reduce the number of deaths in this outbreak, accelerate response to this outbreak, and provide information on optimal care. That's the major point I thought to highlight on this slide. But it's good to say that it took some time, but the PREVAIL partnership in Liberia has been working very well for the population. I did mention the establishment of the National Public Health Institute of Liberia, signed into law in January 2017 to prevent and control public health threats, simply put, to ensure that what happened in Liberia in 2014 does not happen again. And we have a vision of creating a center of excellence for better health outcomes. This is just basically the governance structure of the National Public Health Institute, headed by our board, our Director General in the Department of Technical Services, which are head, and the Department of Administration. These are the core or foundational divisions within the Public Health Institute. I will just skip over this slide in the interest of time. And these are our strategic objectives. Firstly, to build a public health workforce capacity in Liberia, enhance our surveillance and emergency response platform, strengthen the laboratory system and public health diagnosis, provide structures for and protect environment and occupational health, and to conduct and expand and coordinate research activities to inform public health policies in Liberia. For the year 2023, I thought to summarize our strategic directions in line with the purpose of this presentation. So basically, all of these things are guided by these framework documents and lessons learned from the EVD outbreak. As the convener of the International Health Regulations and the National Action Plan for Health Security, the Global Health Security Agenda, the Joint External Evaluation and Investment Plan core areas for public health, building up a resilient health system in Liberia, we've come up with a strategic direction for the National Public Health Institute for the year 2023. And looking basically at strengthening of One Health coordination within the country. One Health is a relatively new concept, but I'm pleased to report to you that across the African continent, Liberia happens to be one of the countries where One Health implementation is in full swing. There are some challenges, yes, with coordination, but we've been able from time to time to mount a One Health response to most of the outbreaks that we've been responding to in recent time, ensuring that we have the human health sector on board, the animal health sector on board, the environmental health sector, and other relevant sectors working collaboratively. We have a National Public Health Reference Lab that has improved in terms of capacity over the period of time between 2016 to now. Prior to the EVD epidemic, the reference lab had a capacity of testing for measles and for measles. That was the only IDSR priority diseases. But as we speak, the platform has enhanced to the extent that we are capable of testing for 14 out of the 21 IDSR priority diseases that we have set as a country to monitor because of their propensity to cause outbreaks. Genomic sequencing is one area where we look highly as a public health institute to strengthen. We've built some capacity in terms of training of our laboratory scientists, and currently working on setting up a sequencing suite that will help us to do high-level molecular analysis for disease pathogens. Capacity building in areas of scientific writings and publication, sustaining and establishing new research partnerships to build a skilled public health workforce and to strengthen our surveillance platform using electronic data collection systems that help us to be able to easily access information and make and interpret those information for public health decision making. Over the 5 years, like I indicated, we've seen significant transformation across the public health landscape in the area of research, improved diagnostic capacity, and improved detection and response to outbreaks. We've also invested significantly in training the few epidemiologists across the country, to the extent that I was writing a proposal a few weeks ago and looking at the Global Health Index index that is developed to look at countries' response capacity. I was surprised to know that in terms of epidemiologists trained per population, Liberia was listed #1. Current research capacities, gaps, and opportunities for partnership. So this campus, this building you see is the Liberian Institute for Biomedical Research. Greg is very much familiar with this building. He has helped us to archive some of the historical information on research and other activities that occurred at NRBR since the 70s up to date. This is where we have the National Public Health Reference Laboratory and the Division of Public Health and Biomedical Research. It was established in the early 70s as a premier research institution in Liberia. There are a lot of scientific breakthroughs, okay, that have occurred as a result of the existence of LIBR. Most notably is the development of hepatitis B vaccine, where animal studies occurred at the time at VLab 2. Some of you may or may not be familiar with the VLab 2 and the work that the New York Blood Center did in Liberia over the period of time that led to development of the hepatitis B vaccine. With the establishment of the National Public Health Institute, this facility was incorporated as a division within NPHIL. And what we look forward to, because we are in the process of co-locating all of our divisions to a massive facility that is being built with support from the US government within the next 2 to 3 years, but at the same time, maintain this research campus so that it is self-sustaining and is adequate and suitable for joint collaborative research projects, including training PhDs within and outside of Liberia. These are some of the current research collaborations that we have in place. I would have loved to go through this project by project so that we understand the public health significance of these research projects that are ongoing in Liberia. But I will just highlight a few in the interest of time. There's currently a seroprevalence of Lassa fever and emerging filoviruses project going on in Liberia in partnership with the University of Hawaii. And this is intended to look at the true measure of the spread of Lassa fever and emerging filoviruses within the population so that we are able to develop strategies to prevent future outbreak. Lassa fever is fast becoming a problem within Liberia. We are seeing increasing number of cases beyond places where were initially thought to not have a Lassa fever. There is also another project that I would like to highlight, and that is the West African One Health Action for Understanding, Preventing, and Mitigating Outbreaks. This is a One Health project also that look at ways in which we could improve infectious disease outbreaks at a community and national level across West African country. We are currently collaborating with Nigeria, Sierra Leone, Guinea, Liberia, and as part of a consortium led by the International Development Research Council in Canada and other partners within the UK, Australia, and other universities around the world. Another research project I would like to highlight is the Acute Febrile Illness Project in Monserrate. We are nearing the end of this project, and often within our setting, when patients go to the health facility, they are diagnosed of malaria whenever you present with fever. Even if the diagnostic test shows negative, we are mainly using a rapid diagnostic test in Liberia. So even where it shows negative, sometimes physicians will still administer anti-malaria, which is against the current treatment guidelines for the country and also contributes to anti-malaria resistance. We all know how chloroquine resistance started in the 90s and it spread across countries that are endemic to malaria. So this, whilst the fever project have yielded some very good preliminary results, we've tested it in 4 facilities across the country, and we feel that the data available to us at the moment may not be sufficient to guide decisions, to inform clinicians, or to update our disease surveillance priority listing. But we are exploring additional opportunities to expand this research to other parts of the country so that we have a representative data that provides the right kind of evidence to inform our policies. So these are other research activities that are currently ongoing in Liberia. I will just skip some of these collaborations. And this is to highlight that in terms of scientific visibility, we've worked in recent time to ensure that we have more publications, more joint research activities being published across the National Public Health Institute. I've already mentioned the laboratory infrastructure and testing capacities, so I will skip this slide in the interest of time. We've talked a little bit about the research gap, looking at funding being a major challenge, limited staffing, and inadequate diagnostic infrastructures. These areas are key focal areas for research for the next year, looking basically at capacity building, exploring opportunities to implement programs to train and support Liberian scientists at postgraduate level or terminal degrees or PhDs, scientific writing and manuscripts, train and make operational or national institutional review board at the National Public Health Institute. Currently within the country, in terms of research ethics regulation, we have a national review board and 2 other local review boards, and we're looking forward to building our own capacity to have institutional review board at the National Public Health Institute. Partnerships, which we know are key to the work that we do. Scientific information sharing. We've initiated a scientific conference that is held annually in memory of Professor Ahmed A. Dennis, who is one of Liberia's most renowned scientists. Professor Midman had the privilege of working with him in past. And to bring together scientists and stakeholders across the country within a region and from outside of the region to share ideas in their work that they do. And in terms of scientific information sharing, to submit abstracts and manuscripts for presentation and publications in journals and other scientific conferences and meetings. Outbreak research, of course, is a priority to us at the National Public Health Institute. To conclude, I will like to indicate that we've had significant impacts from the post-EVD investment in Liberia to strengthen the country's infrastructure and facilitate the human resource capacity in areas of public health. There are, however, some critical areas, especially in research, that need to be addressed. NPHIL has played a major role in transforming the research landscape and coordinating stakeholders to ensure that endogenous-led, relevant, and good quality scientific research is conducted in Liberia. Our focus is to build on the gains from the past, to consolidate our position as a center of excellence for public health and science in Liberia and across the world. We are keen on establishing and maintaining strong and lasting partnerships and collaboration with other health sector actors, including international partners, universities like the University of Wisconsin, research groups with focus on capacity building and joint research activities. And we do acknowledge that key to these partnerships and collaboration is building and maintaining trust, respecting the needs, the interests, and agenda of all collaborators. At this point, I would like to say thank you for your time and for allowing me this opportunity to do this brief presentation. Thank you.
Thank you for the presentation. I'm Abubakar Muhammad from the Department of African Cultural Studies. I have a question regarding the social impacts of those infectious diseases. Especially in Africa, they are attached to so much stigma and so on. So while responding to those medical emergencies, I knew, for instance, in Nigeria, there were a lot of unscientific claims about the healing and medication for those diseases like Ebola, coronavirus. So how would you respond to some of those claims if I were emulating them from various quarters of the society? I mean, there were very unscientific claims. Maybe in Nigeria they would say if you bath with salt water, you'll be immune from Ebola or coronavirus.
All right, so I get you. So, I mean, in a highly society that is highly illiterate is a major challenge for us in terms of outbreak preparedness and response. But what we've been able to do, and even during the EVD epidemic, that was demonstrated that working closely with the community from time to time helps to change the community perception and enables them to act in a positive way, okay, that helps to mitigate some of these outbreaks. We've employed strategies where we've worked with traditional leaders, community leaders, religious groups, influential groups like youth groups, women groups across the country. And in fact, as I mentioned, with the West African One Health project that we're currently implementing, what we've done is to set up community action networks across certain border communities where we've identified as being areas that are prone to outbreaks coming in or leaving the country, to look at how involved those community groups are with detecting outbreaks and helping us to respond to these outbreaks so that they don't spread within a particular geographical location. So that is one key strategy we've employed, to work very closely with the communities. But at the same time, it is critical to state that building trust within the public health system is key, okay? So when there is lack of trust, people resort to other means, okay, of seeking care, and so that is one area that also has to be addressed and looked at more carefully. Thank you.
My question is a little bit related to what you just mentioned, but in a different dimension. And you talked about trust, lack of confidence, and the state, the role of the state. And I think one fundamental aspect of a state is to timely interventions in terms of crisis. So I'm a little bit interested to know what is the role of the state of Liberia in terms of getting people tested when the Ebola just emerged. Citing an example from coronavirus in other African countries or in other parts of the world, some people don't, even this country, people don't believe in COVID. But the efforts to get them tested, I think that's key. That is very essential in terms of know where we're going to get.
Yeah, so that's a very valid point. And to quickly respond to your question, states are governed by laws, and we have a very strong public health law in place where, when it is determined based on the available evidence that the actions of certain individuals or group of individuals put others at risk of public health, of getting infected during these disease outbreaks, there are provisions within the public health law where certain actions could be initiated to stop disease from spreading beyond a particular locale. I will cite a particular instance of the West Point quarantine and the Dolotown quarantine in Liberia. I personally worked in Dolotown, and I was one of those that was in and out to ensure that individuals remain to where they are and provided relief aid for those persons from time to time to ensure that we keep them. It's a whole big conversation because it has to do with the rights of people, but again, where one person's rights end, that's where another person's rights begin. So it has to do with the rights of people. It has to do with ensuring that, especially in places where people survive on daily means, of livelihood, where you may either have to go and sell the market to generate a small income to buy food and feed your kids later in the evening. When instituting these harsh policies and measures, you have to provide some form of emergency relief for these populations. So it's a whole big conversation, but yes, we've had experience during that time from Ebola, and even during the COVID-19 pandemic, there was a time when a state of emergency was being put into place to ensure that people will remain within their communities until much information is known to help inform policies and actions on how to fight the outbreak.
So when you were talking about strengthening the research infrastructure within Liberia, you mentioned how making these global collaborations was key. But then my question to you is, how do you deal with brain drain, or this idea of people from developing countries going to become professionals in developed countries, and how do you ensure that these individuals, or the majority of these individuals, do actually come back and do their research in Liberia?
That's a difficult one because we experience this problem from time to time. And our retention strategy within the health sector, but not only the health sector, but within developing countries in general, it's a challenge, that sometimes you go out, acquire advanced education, and you may find out that in your absence, you've been replaced. When you return, you have no job. Or sometimes you return to similar role. It's a major demotivation, and personally, I've dealt with that from time to time in my role, and I'm even currently dealing with some of those cases. But I usually tell my staff and other professionals that sometimes it depends on what motivates you, So it firstly requires, I think, more engagement with professionals to ensure that they understand what the pasture lies. Okay, everyone wants a greener pasture, but you could make more impact in saving lives by working within a developing country context or setting, as opposed to looking for other opportunities in developing countries where sometimes from time to time you have to do routines and the same thing over and over. I use my own personal experience to motivate my staff, to tell them that the decisions that I took to return to Liberia after completing my postgraduate study has paid off significantly, to the extent that the impacts that we are making within our health system, those impacts, we couldn't have had the opportunity to make them any other place around the world. Some of the engagements and interactions that we've had, the challenges that we have to deal with, and the solutions that we have to find from time to time, those opportunities, you may not get them anywhere. But it's quite understandable that it's a major challenge on retaining skilled and qualified workforce within developing countries. And within the health sector, we'll have to deal with that from time to time to develop the right strategies and the approaches to firstly motivate workers and where applicable provide additional incentives and support. But one key thing is also to ensure that the proper infrastructures are in place to enable them to do their work. I trained as a molecular biologist. I returned to Liberia. I do not have a proper lab to work with. It becomes demotivating. So I think one way the system can ensure that we retain professionals who acquire advanced qualifications outside of the continent to return is to give them the tools to do their work. In that way, there is some level of self-motivation, okay, that they receive from getting to do what they say that they're actually trained to do. So I think that's what I can say with response to your question. Thank you. Okay.
Just like to hear away from your research. So I'm just wondering about the use of traditional, complementary, and alternative medicine during the, the epidemic and how it affected, care, medical care.
Traditional medicine has its own advantage and disadvantage within our setting. And what I can say is that there have been recent efforts to ensure that we work collaboratively. It's not only within Liberia or other developing countries, but even at the level of WHO, to look at ways in which some of those traditional medical approaches could be refined by generating the right kind of evidence so that those interventions or way of treatments are evidence-based. So we can't do away with traditional medicine in our setting, but what I can say is that these kinds of engagements help to ensure that Western medicine and traditional medicine work hand in hand to provide the kinds of care needed within our population. So that basically, I think that will be my response, short response to your concern. Any other?
You spoke about how during the EDD outbreak that a lot of the research was driven by foreign partners, and that things that Liberians wanted to pursue, for example, like supportive care experiments, et cetera, wasn't possible. And I'm just wondering how folks like yourself at NPHIL are really ensuring that these global partnerships are more endogenous led, and that because there's been a past history of very asymmetrical power relationships around research in Liberia because of that U.S. tie, and Liberia really become a kind of laboratory for American biomedical researchers, and I see a real, I mean, there seems to be a real shift in the way in which those research partnerships are being understood and pursued at NPHIL and other institutions in Liberia, and I'm just wondering if you can say how you're going into the understanding of what a research collaboration means now.
Well, firstly, let me say, and as mentioned earlier during the presentation, that the regulatory framework or mechanisms for conduct of public health or biomedical research in Liberia has been strengthened post-EVD. There's been a lot of investments to build the capacity of personnel serving on ethical review boards to firstly understand what they are reading, because that's a challenge in most developing countries where people sit on ethics review board, but they may not have clear insight into some of these kinds of research. You don't have to be a scientist to sit on an ethics review board, but at least to understand some of the ethical issues and implications of some of these research that are being conducted. So firstly is to ensure that those frameworks are in place. Next is to build capacity so that people understand and know what it is that they are reading and what it is that they are dealing with. I had a particular experience back in 2018 when I was initially at the Public Health Institute to be a part of the team with the then Deputy Director General for Technical Services to review a proposal that was submitted by a team that wanted to do a phase 2 clinical trial in Liberia. I mean, understanding the implications, the challenges, we felt that the environment was unfit, and we came up with an appropriate response, okay, to say that, hey, what you want to do is good, but at this stage, we do not have the infrastructure to conduct these kind of studies in Liberia, and these are the ethics implications, and our reputations are at stake because the decisions that we'll make here today are decisions that will affect or may affect the population in the future. So I think that is one area that that is why from time to time as I did this presentation, I did mention capacity building, because the more our capacities are built, you have people making very informed decisions. There are instances where people have signed off on research activities in the past, not understanding exactly what it is that they were signing off to. I mean, I can give lots and lots of examples, but maybe in the interest of time, I will just stop here for now. Thank you.
Thank you so much, Dr. Gilayeneh, for joining us. And we really admire your leadership and your service, both to Liberia and for setting the standard for the rest of us globally for addressing these outbreaks and pandemics. So thank you very much. And thanks everyone for joining us. We will be back in this room in September. Have a great summer.
Thank you.